Good day and welcome to this podcast on the peripheral nerves and neuropathies of the upper limb. This is Dr. Stuart Ingalls. The purpose of this podcast is twofold. First, it serves as a review of the principal nerves of the upper limb as we trace their course, from their proximal origins to distal terminations. Second, it allows us an opportunity to introduce the concept of peripheral neuropathies so that we can discuss the clinical presentation that results from damaging a specific nerve branch, both in the acute and the chronic phase. At first glance, some of these presentations may seem confusing, but a solid understanding of the anatomy of the upper limb helps to make sense of these clinical presentations, while symbiotically, studying the clinical application helps to reinforce your understanding of the underlying anatomy. Before we get into the anatomy of the peripheral nerves, we begin with a general overview of peripheral neuropathies, which can be defined as a partial or complete loss of function resulting from complete or incomplete damage of the peripheral nerve. Peripheral neuropathies stem from multiple causes. One obvious example is mechanical trauma, such as a stab or a crush injury or forces that pull on the nerve enough to tear it. Peripheral nerves are also known to degenerate through chronic exposure to materials like alcohol and certain medications. As chronically elevated blood sugar is known to lead to neural degeneration, certain metabolic diseases such as diabetes may also lead to nerve degeneration if left untreated. In addition to conditions where neural degeneration is a secondary complication, other medical conditions have a direct effect on normal function of nerve cells or neural support cells. Regardless of the cause of the peripheral neuropathy, neural injuries can be broadly classified as being either acute or chronic based on the time frame following the injury. The acute phase is immediately following a neuropathy, which is typically traumatic in nature. It's characterized by a loss of sensation and, in severe enough situations, loss of motor function. But as the injury is in the initial stages, there have not been sufficient time to observe muscular atrophy and joint contracture due to unopposed muscle pull. Peripheral neuropathies typically require months to years to be considered chronic. These are instances of long-term denervation, which can be the result of progressive, advancing denervation, such as in the case of unresolved diabetes, or a low-grade compartment syndrome causing greater and greater degeneration over periods or months or years, such as a case seen with uncontrolled diabetes, or alternatively, a traumatic neural lesion that did not adequately heal and has thus become chronic in nature. In addition to paresthesia and weakness, such as seen as the acute phase, chronic neuropathies are associated with muscle atrophy, leading to noticeable loss in muscle bulk. The lack of pull from a specific muscle group also results in an imbalance in antagonistic muscle pull, which alters the resulting position and the resting position of the joint, a phenomenon known as joint contracture. Finally, for reasons not quite understood, the loss of cutaneous innervation and associated neurotrophic factors results in the thinning in the skin within the affected area, resulting in a shiny luster to this area, brittleness in the skin within the affected area, and loss of hair as well. It is important to remember that these chronic effects may take years to present. In the acute phase, the focus needs to be on loss of function and sensation. One final note to make in general peripheral nerve injuries. The specific location along the course of the nerve is very important in determining loss of function. Only the sensory and motor branches coming off the nerve distal to the site of the lesion will be affected by the injury. Think of these nerve branches as if they were exit ramps off of a highway. Now, let's imagine that there is a major accident that closes all westbound lanes of the I-90 right at the New York-Pennsylvania border. Coming from Buffalo, none of the exits within Pennsylvania would be accessible, but it would not interfere with exits off the I-90 within New York State itself. Similarly, as we will see with nerves, structures supplied by nerve branches distal to a neural lesion will be affected by the injury, but the structures supplied by nerve branches proximal to the site of injury will be unaffected. An in-depth study of the brachial plexus is featured in a separate podcast, which you are encouraged to watch if you haven't already done so. For the sake of the present discussion, we will briefly review the major features of the plexus, then move immediately into the nerve branches that come off. The brachial plexus starts as 5 separate vensal rami that form the roots of the brachial plexus. The upper and lower roots fuse in a characteristic pattern that gives way to the superior, middle, and inferior trunks of the brachial plexus. Each trunk splits to give an anterior and posterior division, and once again we see a characteristic fusion pattern forming the medial, lateral, and posterior cords. Finally, the terminal branches, each of which will be discussed in turn, stem from the cords of the brachial plexus. We start a discussion of the terminal branches with the musculocutaneous nerve, a relatively straightforward branch. The nerve stems from the lateral cord and therefore contains components of the C5, C6, and C7 spinal nerves. The nerve typically enters the anterior compartment of the arm by piercing the coracobrachialis muscle, which it consequently innervates. It then continues its course through the anterior compartment, giving off additional muscular branches to the remaining muscles within the compartment, before the terminal cutaneous portion emerges from between the biceps brachii and brachialis muscles to supply cutaneous innervation to the lateral aspect of the forearm. The musculocutaneous nerve is generally well protected from injury, and therefore isolated injuries are rare. The anterior compartment is, however, highly affected by injuries to the upper roots of the brachial plexus. These may result from awkward falls that cause excessive lateral net flexion or difficult deliveries, in which excessive traction is placed on the neonate's neck area. As the accompanying diagram demonstrates, the anterior compartment of the arm is highly affected, and the individual has difficulty flexing at the elbow. This results in what is often referred to as the waiter's tip hand position, in which the elbow appears extended, the shoulder internally rotated, and the wrist flexed, resembling a maitre d' hinting for a payoff for special accommodations. We next move to a discussion of the median nerve. The median nerve is formed from contributions from both medial and lateral cords, and therefore contains fibers from all 5 root levels. Following fusion of the medial and lateral cord contributions, the median nerve courses through the brachium just medial to the brachial artery, entering the medial aspect of the cubital fossa. At this point, the nerve gives off numerous motor branches to the superficial muscles in the anterior compartment, including the pronator teres muscle. The median nerve then enters the anterior compartment by passing through the superficial humeral and deep ulnar heads of pronator teres. This represents a common spot for medial nerve compression, as tightness of the pronator teres can compress the median nerve, resulting in a condition referred to as pronator teres syndrome. The median nerve gives off an anterior interosseous branch that lies deep in the anterior compartment, and together these supply branches to all of the muscles of the anterior forearm save one. As the main branch of the median nerve approaches the carpal tunnel, it gives off a cutaneous branch that supplies the skin along the anterolateral aspect of the palm. The nerve then passes under the carpal tunnel to enter the palmar aspect of the hand. The carpal tunnel represents another common site of median nerve impingement, resulting in the condition commonly known as carpal tunnel syndrome. We could trace the median nerve distal to its passage through the carpal tunnel. As it emerges from the carpal tunnel, it supplies a recurrent branch to the thenar eminence, which is the motor innervation for these muscles. Because of the importance of thumb opposition in regular activities of daily life, the recurring branch of the median nerve is commonly referred to as the $1 million nerve, due to its importance in supplying the muscles that serve this vital function. The remainder of the median nerve continues as the common digital branches towards the webbing between the 1st through 4th digits. Here we see 2 additional motor branches that supply the lateral 2 lumbricals. This represents the extent of motor innervation from the median nerve within the palm of the hand. Every other muscle we will encounter is innervated by the ulnar nerve. The common digital branches will then split to form the proper digital branches that progress to the distal tips of the fingers and provide cutaneous sensation for the lateral 4.5 digits. Before addressing different median nerve lesions, we will also trace the course of the ulnar nerve, which complements the median nerve in the muscles that it innervates. The ulnar nerve branches from the medial cord and thus contains neurons originating from the C8 and T1 spinal nerves. It then courses through the brachium in the medial compartment, similar to what we observe with the median nerve. Also similar to the median nerve, the ulnar nerve does not actually supply any sensory or motor branches within the brachium itself. Where the 2 nerves differ is in the paths that they take as they course through the brachium. As previously discussed, the median nerve lies medial to the brachial artery and emerges in the cubital fossa anterior to the distal end of the humerus. The ulnar nerve, on the other hand, pierces through the medial intermuscular septum and passes posterior to the medial epicondyle of the humerus. This represents a common site of impingement where sharp edges of tables and desks often catch within the wedge found between the medial epicondyle and the olecranon process, compressing the ulnar nerve. This region is known as the cubital tunnel and is responsible for the infamous funny bone phenomenon we're all familiar with. Chronic impingement is quite common in this region and is commonly referred to as cubital tunnel syndrome. The ulnar nerve enters the forearm by passing under the tendinous arch joining the humeral and ulnar heads of the flexor carpi ulnaris muscle. As it does, it gives off motor branches to both the flexor carpi ulnaris and flexor digitorum profundus muscles. While the flexor digitorum profundus muscle is dually innervated by both the median and ulnar nerves, the flexor carpi ulnaris muscle is exclusively innervated by the ulnar nerve alone. Pretty simple to remember this exception to the rule for median nerve innervation to the anterior compartment. The one muscle innervated exclusively by the ulnar nerve is the one muscle with ulnar in its name. The ulnar nerve enters the hand just lateral to the pisiform bone and the hook of the hamate, protected to a certain degree by the palmaris brevis muscle. This forms the ulnar tunnel or Guillaume's canal and is yet another site of impingement for the ulnar nerve. This is a common problem for cyclists because of the danger of prolonged compression from leaning forward on handlebars. It's important to note that the ulnar nerve passes superficial to the deep transverse carpal ligament that forms the roof of the carpal tunnel, which means that, unlike the median nerve, the ulnar nerve is not compromised in carpal tunnel syndrome. Past the ulnar tunnel, the superficial branch of ulnar nerve projects to digits 4 and 5, while the deep branch runs through the space between the central and interosseous compartments of the hand. Looking at this distribution in greater detail, we see a similar branching in the superficial branch of the ulnar nerve as was seen in the median nerve. A motor branch supplies the hypothenar eminence, and the remainder of the nerve courses to the 4th and 5th digits as the common digital nerves, which then split to form the digital branches to the little finger and medial half of the ring finger. This is the reason why, if you pay close attention, that only the medial half of your ring finger tingles when you hit your funny bone. The deep branch pierces the hypothenar eminence, branching extensively as it courses to supply all of the intrinsic muscles of the hand, save for the muscles previously described that were innervated by the median nerve. Having completed our extensive discussion of the median and ulnar nerves, we're almost ready to discuss the effects of injuries to these two nerves. First, however, consider the function of the intrinsic hand muscles they innervate. As discussed in the lecture on the hand, the lumbricals and interossei all cross ventral to the metacarpal phalangeal joint, but attach on the extensor hood running distal to the interphalangeal joints. As a result, a major function of the intrinsic hand muscles is to flex the MCP joint and extend the interphalangeal joints. Consider what would happen if we were to lose all of the intrinsic hand muscle function. This actually occurs with traction injuries to the lower roots of the brachial plexus, commonly referred to as Klumpke's palsy. This may result from forceful abduction of the arm, such as from grabbing onto an object to break one's fall, or again during a difficult delivery. It turns out that the intrinsic hand muscles are all innervated by the lower root levels. Consequently, this injury tends to affect these muscles exclusively. With the loss of the pull these muscles create, the antagonistic muscles take over. This forces the MCP joints into extension and the interphalangeal joints into flexion, the opposite of what the now paralyzed intrinsic hand muscles actually do. This results in the claw hand deformity characteristic of Klumpke's palsy and viewed here. Now let's consider what happens with lesions to the distal median nerve, such as we see in carpal tunnel syndrome. In this instance, only the branches distal to the tunnel are affected. This includes the all-important recurrent branch to the thenar eminence, resulting in thenar atrophy and contracture of the thumb into an extended position. This results in the ape hand deformity due to the loss of opposition of the thumb, and the resemblance of the hand to that of the great apes. Note that, although we also lose the lateral two lumbricals, the movements of the index and middle finger are only slightly affected due to the presence of the dorsal and palmar interossei, which are innervated by the ulnar nerve. Therefore, we only see minimal clawing, if any at all. If the injury is more proximal, as is seen in Pronator Thierry syndrome, we still lose the distal nerve segments, but now also lose innervation to the anterior compartment of the forearm, which includes the long digital flexors. The patient will now show forearm wasting and weakness in digital flexion. Remember, however, that the medialmost portion of flexor digitorum profundus is innervated by the ulnar nerve, which means that flexion to the fourth and fifth digit are partially spared when the ulnar nerve is unaffected. This results in what is known as the hand of benediction sign, when the patient is asked to make a fist, due to the resemblance of the hand of a Catholic priest during a blessing. Now let's consider ulnar nerve injuries. A distal injury, such as is seen in the ulnar tunnel, results in loss to most of the intrinsic muscles of the hand. As with Klumpke's palsy, this results in significant atrophy of the hand and clawing of the digits. The distinction here is that, because the median nerve is not affected, the first two lumbricals are still active. As a result, clawing is much less severe in the index and the middle finger, and thumb opposition is still permissible. This results in the characteristic ulnar claw shown here, with greater clawing of the fourth and fifth digits. It's important to note that, while this may superficially resemble the hand of benediction sign we just discussed, it is a completely different phenomenon. First, the hand of benediction is only seen when the patient is asked to make a fist, whereas the ulnar claw is seen when the hand is in a resting position. Second, there is a complete reversal in the hand muscles that experience atrophy. Note that here the thenar eminence appears normal and there is no ape hand deformity, which is expected with any sort of median nerve injury. Looking at a more proximal ulnar nerve injury, such as with cubital tunnel syndrome, we see an interesting phenomenon. In addition to losing most of our intrinsic hand muscles, we also lose the ulnar contribution to the flexor digitorum profundus. So as a result, the patient has difficulty flexing the distalmost interphalangeal joints for the fourth and fifth digits. This results in a phenomenon known as the ulnar paradox. A more proximal ulnar nerve injury, as depicted in image B, affects more muscles than a distal injury, as depicted in A, but actually results in less deformity. This is because the more proximal flexor carpi ulnaris and distal intrinsic hand muscles have opposite effects on the distal interphalangeal joints, so losing both of them negates the effect at this specific joint. As we can see in A, flexor digitorum profundus is still intact in a distal injury, and so consequently, we do see greater clawing. We now return to our discussion of nerves with a look at the two major nerves off the posterior cord of the brachial plexus. First, we have the axillary nerve. This is the branch that passes through the quadrangular space to pass posterior to the neck of the humerus. It terminates in numerous motor branches that supply the teres minor and the deltoid muscle, as well as a cutaneous branch to the posterior aspect of the shoulder. Not surprisingly, damage to this nerve, which is not uncommon following anterior shoulder dislocations or fractures to the surgical neck of the humerus, can result in deltoid atrophy and in difficulties in abducting the arm. The last nerve we will consider is the radial nerve, which courses through the spiral groove posterior to the humerus. As it does, it gives off numerous motor and sensory branches to the tricep muscle and the posterior skin of the arm. The nerve then courses anterior to the elbow before piercing through the supinator muscle to supply deep branches to the muscles of the forearm. As with Pronator Thierry syndrome, supinator syndrome results in compression of the deep branch of the radial nerve and weakness with wrist extension. This results in a phenomenon known as wrist drop, which describes the presentation when the patient is asked to hold the wrist up against gravity. The radial nerve can also be injured at the level of the axilla due to prolonged compression when the arm is slung across an object for support. Traditionally, the term Saturday night palsy has been coined because of the risk of sleeping in awkward positions on desk chairs, couches, and park benches following a night of heavy drinking. Another common mechanism of injury is from an ill-fitting crutch pushing into the axilla. A very simple test for radial nerve compression is by rubbing the skin over the dorsal webbing of the thumb. Since this is supplied by the superficial branch of the radial nerve, compression along any part of the radial nerve will lead to sensory changes early on that can serve as a red flag that the crutch is not being placed properly. This concludes this podcast of the upper limb nerves and neuropathies. Until next time, this has been Dr. Stuart Ingalls. Enjoy the rest of your day.